Good morning, friends. Today, our guest speaker is Dr. Sanjeev from Lucknow. He'll be speaking on CML management, redefining clinical goals in early CML management. After this, we have second speaker, Dr. Delphine Ree from Paris. She will speak to us on CML again, the possible changes in the treatment of first-line setting in 2024-25. These webinars are brought to you by Mumbai Hematology Group. Today's webinar is supported by Novartis, Natco, Accurent, and Nirvil, managed by Perfect Square. I thank Team Novartis, Natco, Accurent, and Nirvin, Mr. Yash Kalpesh, and the team from Perfect Square, Executive Committee of Mumbai Hematology Group, our chief guest of the day, Dr. Rohan Bise from Belgavi, our guest speakers, Dr. Sanjeev from India and Dr. Delphine Ree from France. All our discussants were themselves eminent hematologists and hemato-oncologists, and you participants for sparing your Sunday morning. Next week, Saturday, 19th October, 7 p.m. onwards, we have Dr. Christian Hoffman from Germany speaking to us on Kesselman disease. And next Sunday morning, we have Dr. Philippe Maurier from France speaking to us on treatment of relapsed refractory multiple myeloma, both early and late relapses at 11:30 a.m., the French time 8 a.m. Discussants today, and we have a good number of them from all over India and surrounding countries. Briefly, we have Dr. A.K. Ganju from Nagpur, Dr. Abhijit Baheti, Pune, Dr. Abhijit Giram, Pune, Dr. Akanksha Garg, Ahmedabad, Dr. Akanksha Salkar, Nagpur, Dr. Amit Khurana, Surat, Dr. Amit Singh, Airom, Imphal, Dr. Ankit Batra, Dehradun, Dr. Aniket Mohite, Pune, Dr. Ankur Ahuja, Pune, Colonel Dr. Ashok Meshram, Kolkata, Dr. Avriti Baveja, Dehradun, Dr. Fahima Hassan, Prayagraj, Group Captain Dr. Harshit Khurana, Pune, Dr. Nin Mia Thanda from Myanmar, Dr. Ketan Modak from Nagpur, Dr. Kripa Bajaj from Hyderabad, Dr. Kunal Chattani from Nagpur, Dr. Kunal Goel from Mumbai, Dr. Liza Bulsara from Pune, Professor M.A. Khan from Dhaka, Bangladesh, Dr. Mohammad Mir Hussain from SKIMS, Srinagar, Dr. Narendra Kumar Chaudhary from AIMS, Bhopal, Dr. Nishad Dhakate from Nagpur, Dr. Raghuvendra Rajeshwarkar from Solapur, Dr. Rahul Arora from Nagpur, Dr. Rajat Bajaj from Nagpur, Dr. Sadashivudu Gundeti from Hyderabad, Dr. Sandeep Barteke from Pune, Dr. Sailesh Lavana from Vadodara, Dr. Sriram Kane from Nagpur, Dr. Urmimala Bhattacharjee from, he is at the moment in UK, Dr. Varun Bafna from Kolhapur, Dr. Vishudeep Kushu from Nagpur, Dr. Yi Moon Thand from Myanmar. And now to introduce our special guest for the day, Dr. Rohan Bise from Belgavi. I'm extremely grateful to him for sparing his time and joining us to inaugurate our today's webinar and address us. He's professor and head, consultant medical oncologist and hemato-oncologist at Department of Medical Oncology at the prestigious KLE Dr. Prabhakar Kore Hospital and Medical Research Care Center, Belgavi. I request him to inaugurate our webinar and give us some words of wisdom.
Good morning, sir. Thank you for the kind introduction. I thank Dr. M.B. Agarwal and MAG for providing me with this opportunity to share my thoughts in this forum. I admire the work done by MAG and Dr. M.B. Agarwal in disseminating the knowledge in hematology across various forums and request them to continue the same. This requires great effort, time, and dedication. I am personally benefited a lot by attending to various lectures given by the esteemed international and national faculty. As ours is a knowledge-based field, being up to date with new data and research is important and MHG gives me the opportunity to stay updated. The forum also allows me to learn from the way various experts practice. I did my DM at Kizwai Medical Oncology Institute, Bangalore, and had an opportunity to join the institute at completion. However, so I was inclined to work at my hometown, Belgavi. I joined Jain Medical College with an intent to fill the void in medical oncology. We started the department in 2013. Since then, we have progressed a lot. We now have a 300 bedded new standalone cancer hospital with a surgical oncology department with access to robotic surgeries, a full-fledged pediatric oncology department with upcoming facility for transplant, a radiation oncology department with two state-of-the-art radiation machines. We have a good backup from interventional radiology and nuclear medicine department. We run DM medical oncology courses, MCH surgical oncology courses, and have applied for MD radiotherapy. So to say, a full-fledged setup for both academics and patient care, catering to regional population, both to the rich and the poor. More than 50% of the population is treated under various government schemes. The message that I would want to disseminate to budding specialists who normally want to practice in a bigger city like Bombay, Pune, is that there is a big requirement for oncologists in tier 2 cities. So there is a lot of scope for them in various medical colleges where infrastructure can be made easily available. They can strike a balance between practice and academics. The infrastructure and connectivity in tier 2 cities is rapidly improving. The cost of living is less time is spent on travel, lesser pollution, and less time is required to establish their practice. Hence, I think this is a great opportunity for budding oncologists. Once again, I thank MHG and Dr. M.B. Agarwal for providing me with this opportunity. Thank you for patiently listening.
Thank you so
Thank
much,
you, sir.
Dr. Rohan Bise, for those kind words, introducing the setup that you are working in, and also inviting our young colleagues to tier 2 cities to benefit the patients over there without traveling to major cities. The message was apt. Thank you very much.
Thank you, sir.
I now invite our first guest speaker of the day, and that is Dr. Sanjeev Lucknow. It's my pleasure to introduce my friend Dr. Sanjeev. I don't think he needs an introduction. Everybody knows him in the field of hematology. But as we have a large number of global audience, let me do the formalities of putting him to all of you. He's additional professor in the Department of Hematology at the prestigious SGPGI Lucknow. He is a hematologist, hemato-oncologist, and a bone marrow transplant physician. He has special interest in hemophilia and bleeding disorders. He did his DM in clinical hematology from SGPGI itself way back in 2015. He did PDCC hemato-oncology from again SGPGI in 2012. Earlier, he did his MD in internal medicine from VSS Medical College, Burla in 2010. He was consultant at BGS Global Hospital as well. He is a member of ASH, EHA, European Bone Marrow Transplantation, Indian Society of Hematology and Blood Transfusion, Indian Society of Bone Marrow Transplantation, and Indian Myeloma Group Image. I request him to give his talk on CML management, redefining clinical goals in early CML management. Over to you.
Thank you, sir. I think my slide is visible.
Yes, sir.
Yes. Good morning, everyone. This is the very important platform for knowing hematology in more better way collectively. And Mumbai Hematology Group gives that platform. Today we will discuss about the CML management. Initially, I will discuss about the CML management in India, what practice we are doing, and later on another guest speaker. She will tell us about what needs to be changed. Uh, this is a sponsored slide provided by Novartis Healthcare Private Limited. My discussion points are in evaluation of CML goals in past 20 years. Uh, CML was a disease which was hardly treatable 20 years back before the discovery of imatinib. Then after imatinib, it has a long course of next 10 years in which there was a very good survival with imatinib and peoples have almost normal life expectancy. And then now we are targeting TFR and other different goals. Then I will discuss about the Indian scenario in management, what are the treatment options available, and why there is a need of individualized treatment approach for patients of CML. This is the first initial year where the abolish the disease progression from the chronic to the blastic phase and guarantee the long-term survival was the main goal in the great majority of patients. In next 10 years, the main objective of CML therapy moved from survival to treatment-free remission. And today's individualized patient care targets the treating patients to important treatment paradigm, and we have to consider the patient's age, comorbidities, their tolerability, and specific objective means personalized care for each and every individual of CML. The use of TKI has led to a life expectancy for patients with CML close to the general population. Almost at 5 years, 95% patients are surviving, and at 10 years, 88% are surviving. And with deeper responses and correlated with the overall survival, we can have a very high 10-year survival in patients of CML. But it's all Western data. What is the Indian scenario? In Indian scenario, we also have very good major molecular response, mostly with imatinib based trial. The publication with second generation TKIs is usually not available, and but one significant difference that we can see comparing the Western data with the Indian data, the MMR is a less percentage in our Indian studies compared to the Western population. These MMR rates at 12 months are significantly lesser as compared to the data from the Western population in clinical trials, and there is a very limited data on the second generation TKI. This is the still reduced, but burden is still high in India. The highest incidence is in India, the highest death rate is in India, and the highest dailies in India. There is a early age of presentation with a higher social risk. We have a good number of cases who are adolescent and even children. The socio-economic considerations are important. There is a lack of optimal and regular disease monitoring. Drug non-compliance and lack of adherence to the treatment is very common. There is high disease bulk and advanced stage at diagnosis. That is usually not seen in Western countries. Most of the patient you can see with very large spleen, very high TLC, even people presenting with complications of very high TLC like deafness or optic neuropathy, priapism. It is very commonly seen in patients in CML. Coming to the next discussion point, this is the overall evolution of the Indian CML patients. Initially, the goal of management was the uh, quality of life, deeper response, and treatment-free remission. And now the monitoring milestones that we need to follow as per the ELN guidelines. but um, most of the patients have lack of adherence to the ELN guidelines, and hematologically responses are usually monitored only. BCR ABL monitoring is not stringent in many of the centers. Treatment switches are not as per the ELN guidelines, and majority of the treatment switches are delayed by different time intervals. And the most important and alarming thing, there is a lack of patient participation in decision making. So to achieve our advanced goal in our Indian patients, patient participation in decision making is very important. And targeting treatment free remission, that is one area where we have to grow, because many physicians are still not trying for the treatment free remission. And another important area where we need to work is the quality of life, because imatinib provides the best quality of life among TKIs, but second generation TKIs, which have some known adverse effect, but with that, how can we have a better quality of life and early achievement of treatment free remission, that we need to discuss. This is the understanding the patient perspective through the quality of life questionnaires. The most important treatment factors for patients on first generation TKI are the stop or slow down the disease progression. That is the most important thing that everyone wants to know, and to maintain or improve a good quality of life. So this is two important questions that everyone wants to know in their treatment goals for any individual. And other important questions are the does white cell count will be normal, minimize risk of severe side effect, TFR, MMR, DMR. These are the less important questions as per the treatment practice in India. Coming to the basic information that is received regarding the treatment of patients on first generation TKI, there is a very limited information. Uh, the most important information that they have is how to take the treatment and how long I will take the treatment. Information about follow-up visits, usually monthly visits for first 3 months, then 3 monthly follow-up. And if patient is losing the deep molecular response, then more frequent visits may be required. And there are questions regarding how the treatment may affected my quality of life, potential side effects, how to manage them, information about eventually stopping the treatment or treatment-free remission, and instruction information about non-medical aspects like food, diet, meal schedules, restriction. These are important questions that should be asked from each and every patients, and they should be counseled regarding this. Coming to the next discussion point, what are the treatment option available? So we have first generation TKI, second generation TKI. We have imatinib, nilotinib, dasatinib, bosutinib. Ponatinib is not available in India, but we are procuring it by different means. And now asciminib is also available. So now we have multiple options for patient to bring them into deep molecular response as early as possible and put them into TFR. And it is the time that we should also discuss about a good quality of life, how to achieve a good quality of life for our CML patient. Means CML therapy has to be individualized based on patient's clinical condition and comorbidities. And because most kinase inhibitors target the kinase ATPs, there is a potential for cross reactivity. ATP competitive TKIs approved in CML therapy bind to the kinase in addition to their intended target, and there is a off-label binding that can modulate the uni-intended biological pathways and may contribute to short and long-term safety profile of TKIs. So we are well aware of different side effects of nilotinib, dasatinib, ponatinib, bosutinib, and there are subset of patients where we have to use based on that. Like in a patient with a uh, pancreatitis history, we can't use nilotinib. If in patient having a pulmonary complication, we don't use dasatinib. Like in a patient having a GI toxicity, previous history of GI disorders, we don't use bosutinib. In patient having cardiac problem, we don't use ponatinib. So these are the known toxicities that we are well aware, and we have to plan treatment based on the patient's personalized approach, and patient's comorbidities has to be taken care during planning the treatment. This is the well known that higher efficacy is there with second generation TKI. Different trials has shown it, like Iris, Ernest, Decision trial, all have shown, Pela trial, all have shown that generation TKIs has better uh, they are more potent, and they have better disease remission, deeper disease remission, and early disease remission. And considering the Indian scenario and the increasing need for the individualization of treatment, let us look at the advanced goal that we can aim in a newly diagnosed patient. So quality of life is an important treatment goal, and as patients with CML may require lifelong treatment, we need to focus on this part of treatment. For that, we have to make patient as a part of our treatment decisions. Although roughly 50% of patients diagnosed with CML are asymptomatic, and treatment related symptoms can have a negative impact and quality of life, uh, to be stay adhere to the treatment. This is a survey of 86 patients with CML on TKI that has showed 97% patient have one or more drug related adverse effect. 50% said that adverse effect negatively affect the quality of life, and 25% have adverse effect affecting mood, general condition, and life enjoyment. And for that reasons, quality of life can decline along the disease treatment trajectory due to symptoms burden and treatment toxicities. So this is an important consideration in the current practice of treatment of CML that we have to consider in our planning of treatment. Why to consider TFR? Because it has been well documented that the prolonged use of TKI is associated with clinical relevant adverse effects such as cardiovascular problem, pleural effusion, fatigue, muscular pain, and possible increase in incidence of second cancer. And high cost of indefinite TKI treatment has become a burden to the healthcare, especially second generation TKI. And recent study have shown the feasibility of TFR after discontinuation of second generation TKI in CML patient who have maintained MR 4.5 for 12 months after more than 2 years of TKI therapy in the first line or second line setting. So there are more and more studies on TFR which gives us more and more confident to stop these drugs if patients are doing very well and maintaining a deep molecular response with the first or second generation TKI. Uh, to avoid the long-term toxicity of TKIs, we should put patients on TFR. This is the different TFR recommendation by the NCCN and ELN. It is a summarized. Discontinuation of therapy in stable DMR to achieve and maintain TFR is an important goal for CML treatment now. Depth of response and the duration of response achieved at the time of treatment discontinuation are important key for TFR. And the first line treatment with second generation TKR leads to more rapid DMR, and more patient can be put in TFR. So this has been main outcome of different studies that has been done in last 10 years for TFR. There is a need to balance the safety with efficacy. The primary reason for discontinuation in newly diagnosed patient due to intolerance is higher than due to lack of efficacy. So in different studies, it has been shown that intolerance and resistance is the primary reason for discontinuation rather than the low efficacy of the drug. And there are data from the pivotal trial that TKIs in newly diagnosed patients report overall discontinuation rate ranging from 28% to 63.7%. So it is a high percent. This is the 3-year simplicity data where intolerance is a key driver for switching treatment early. European simplicity data of 431 patients have shown they were followed for 3 years. The proportion of patients switching TKI was highest in the first year of first line TKI treatment. The highest number of patients switching treatment in the first and second years of TKI treatment were those who receiving first line imatinib, and the intolerance was the most common primary reason for switching, followed by the primary resistance and acquired resistance. So there are no similar studies from India, but in our practice also we can notice this is happening. Those patients who are on first line imatinib, they have highest rate of switching to second generation TKI, mostly due to intolerance, or sometimes it's due to not achieving the ELN targets. This is the pattern of adverse effect causing higher discontinuation from the simplicity data. We can see that imatinib was responsible for highest number of treatment discontinuation and switches across years and highest rate in the first year of treatment. Intolerance were the most common reason for discontinuation and switches across TKIs, and the general disorders including asthenia, chills, discomfort, edema, fatigue, mucosal inflammation, pain, pyrexia, swelling, and GI toxicity were the reasons for different treatment discontinuation. What is the impact of patient participation? Patient participation in decision making improves the satisfaction of treatment. Survey from the 1133 patients completed the questionnaires. Of them 58.1% were male and 41% 1.9% were female. The study suggests that the higher level of satisfaction with more information received and the increased knowledge about treatment-free remission is very necessary. Discussion of TFRs illustrated the importance of deep molecular response and possible discontinuation. So this study was done by in Korea between 2005 and 2013, and they have also shown that adherence was measured according to the medication possession ratio, which was calculated as the number of days of medicine was supplied for divided by the number of days between the first refill and last follow. Higher adherence has increased probability of survival. So this kind of studies are needed more and more, especially about the quality of life in our current practice also. And uh, intolerance can also result in intentional non-adherence, which may decrease a patient probability of achieving optimal response to treatment. In this study, 6-year probability of molecular responses according to the adherence rate, we can see. Can we look at simpler tool or trackers to monitor quality of life and efficacy to better manage CML? Yes, CML, BCR, ABL, adverse events, and quality of life tracker can be utilized in our clinical practice. This is a kind of tracker that is prepared by Novartis, and it is a BCR ABL tracker. Patient themselves can plot their BCR label according to the timeline, and tracker is devised to help patients to keep a tab on adverse events as well as BCR labels for discussion with the practitioner. The patients can fill in the date, enter the physical event they experience, and select the number that best rate your experience, intensity, and quality of life. And while when they visit the physician, they can show this tracker to the physician, and we can have a very good idea about the disease and what is the input of patient on his disease. That can be easily evaluated through this tracker. To summarize, the specific goals are vary in patients. Achievement of milestones may be like to improved outcome, including reduced progression and prolonged survival. What should be the goal in newly diagnosed patient? Treatment goals need to be focused on controlling CML pathology while preserving quality of life. TFR and rapid and durable achievement of milestones in terms of EMR, DMR, or MMR is required, and patient participation in decision making improves adherence and thus improve patient outcome. This is the most important point, which currently we are not very much practicing. This has to be incorporated in our clinical practice so that patient should be patient's decision should be respected and included in the decision making. Goals in the older patients with multiple treatments, maintaining quality of life with less aggressive milestone goals that is needed. uh, Whatever our ELN goals, that should be a little flexible for elderly patients with multiple comorbidity. With that, I am finishing my talk. Thank you.
Thank you, Sanjeev, for that wonderful talk and educating us about CML, especially in India. Um, our colleagues are here if they would like to ask you any questions before we invite Dr. Delphine for her talk. Okay, in case there are no questions at the moment, and if Dr. Sanjeev is with us towards the end of second lecture, we can have interactive session with him again. So it's my pleasure now to introduce our guest speaker, Dr. Delphine Ria from Paris. Mm, She is MD, PhD, Department of Hematology, Saint Louis University Hospital, Paris, France. She's deeply involved in the work of chronic myeloid leukemia, and she has published extensively, including on asciminib, which is the hottest of the subject at the moment. She's going to speak to us on CML, the possible changes in the treatment of first-line setting in the current year and the year to come. To stop here and invite her to give her talk. Dr. Ria.
Dear Professor Agarwal, dear colleagues from the Mumbai Hematology Group and all over India, thank you very much for your kind invitation for this lecture and to participate to your very interesting discussion. I will try first to share my slides. It's a technical challenge for me. So here, share. I think I have to share it as full screen. Can you tell me whether it's fine?
Absolutely. Perfect.
Thank you very much. So indeed, possible changes in the first line setting this year or the years to come. And before I start, here are my disclosures. As you all know, with ATP competitive TKI, patients with CML who have access to treatments can recover near to normal life expectancy with a very, very high overall survival and progression-free survival. And here you see the results over 10 years of patients who were treated either with imatinib first line or with second generation TKI first line. It was nilotinib here, and with overall survival rate comprising CML-related deaths and non-CML-related deaths very, very high. And there was no difference between imatinib and second gen, but in fact, what we need to know is that the overall survival and PFS in clinical trials are captured whether patients are still on the first-line drug or whether they switched. So it is very important to remember that this overall survival, this very high rate, is achieved only because ATP competitive TKI can provide high level of protective response, durability of such responses, but also a very important condition is that the patient have access to the front line, but also to the salvage option whenever needed. And here are the current weapons that we have to achieve such a very important goal as survival. And of course, you know all of these tools. In the first line setting, we are used to use ATP competitive TKI, of course, imatinib and the second generation tyrosine kinase inhibitors. In the second line setting, there is more options to come. The third generation ATP competitive TKI, ponatinib in case of failure of second gen first line, or in case of emergence of the T315I gatekeeper mutation. In China, the old verembatinib, which is a modified ponatinib. And in the third line setting, all of these ATP competitive TKIs plus asciminib, the famous and first allosteric TKI available in CML. And asciminib is now being tested in the first line setting due to this high level of response, third line, and also this very interesting tolerance profile. What we also know is that the survival I was talking about, which is a key goal, we measure it using surrogate markers and especially molecular responses. And as you all know, the early molecular response is very important, and especially this 10% threshold. And you see here in the decision study, which compared imatinib first line with dasatinib first line, that the patient who have less than 10% BCR at 3 months have a very favorable overall survival, more than 90% at 5 years, both with imatinib and dasatinib, and that the patient who have still a very high residual disease burden at 3 months need rescue, because if they are not rescued, then the overall survival rates drop by more than 10% due to transformation event. And when we use a more potent drug than imatinib, such as second-gen TKI, the number of patients who fall in the category of early molecular responders is much higher. You see with dasatinib, 84% of the patients had less than 10% BCR-ABL at 3 months. It was only 64% with imatinib. So using a more potent TKI than just imatinib is very important for survival. But once survival is achieved, when the patient is protected by achieving a protective response, there are other factors that come to the forefront. And this has been recognized by both European Leukemia Net and also NCCN and also some country-specific working groups. And you see already more than 10 years ago, the European Leukemia Net recognized that although survival was a very ambitious and a key goal, there were other factors such as quality of life and also later on living without a treatment, which is in other words called treatment-free remission. And in 2020, these very important goals were repeated by the ELN experts. You see that now that the life expectancy of newly diagnosed patients is very close to that of age-matched individuals in the general populations, at least where all drugs are available and where patients can be salvaged upon a need beyond the first-line setting. Then there is an increasing focus on other goals such as quality of life, avoiding long-term organ toxicities, and maximizing the possibility to stop the treatment. So where are we now in terms of treatment-free remission? ATP competitive TKI, you see here again that the molecular responses during the first year of treatment give a very good indication of what will happen and whether TFR will be feasible 5 years later. Here, these data come from the NSTND trial where imatinib first line was compared to nilotinib first line, and this is here a landmark analysis showing the cumulative incidence of deep molecular responses. Here it was MR4.5, which is a condition for stopping treatment. by BCR-ABL levels at 3 months. And you can see that we can already recognize the patient to have very good chance to start therapy later on by using this kind of tools. And the patients who already have a decrease of the residual disease burden of less than 1% by 3 months have more than 60% chance of reaching deep molecular responses later on, whether regardless of which TKI you use at the beginning. But of course, the number of patients who have such a very important reduction of the residual disease burden is much more important when you use potent TKIs. You see that half of the patients treated with nilotinib achieved this less than 1% molecular response at 3 months, whereas it was only 43 out of 283 with imatinib. And when the residual disease remains very high, like more than 10% at 3 months, then if we really want TFR as a goal, we need to change the strategy, because the probability to reach a deep molecular response later on is close to 0. So we have ATP competitive TKIs, which are able to provide a high progression-free survival and overall survival whenever available everywhere, and whenever a salvage therapy can be used. We also have access to TFR, but significant progress to be made, as you can see. Maybe half of the patients with ATP competitive TKI second gen will be candidate for stopping treatment, and much less with imatinib. And another issue is the tolerance of these drugs. As you've heard before from our colleague, these ATP competitive TKIs that we currently have are not very selective, which means that they inhibit a bunch of other kinases in a significant fashion. And they also have some effects on proteins which are non-kinases, and this explains the toxicity profile of this medication. And we know that second gen and third generation ATP competitive TKI have potentially very serious toxicities. With nilotinib, we all know about the increased risk of newly occurring or worsening cardiovascular risk, which requests to assess the cardiovascular risk and also to assess the metabolic profile of the patient before and during treatment. With dasatinib, we have a high risk of pulmonary artery disease and pleural effusion, which makes patients with already lung disease very fragile with respect to this kind of toxicity. With bosutinib, we have frequent GI tox and also hepatotoxicity, which may lead to treatment discontinuation. And with ponatinib, we have arterial hypertension and also an increased risk of newly occurring and worsening CVD risk. So in patients, we may face to newly or prematurely occurring comorbidity or a worsening of pre-existing comorbidities. And this, of course, will not only impair the quality of life and require a treatment change, but also may provide a significant comorbid burden besides CML. Now, we also know that these TKIs, especially imatinib, but not only imatinib, they may also lead to low-grade side effects. Adverse drug reaction is ADR on this slide. And this ADR, although of low grade, they may significantly impact the daily life. And especially when you are told usually that the side effects usually occur during the first months of treatment and usually decrease in intensity or in frequency, but this is not always true. With imatinib, we perfectly know that the chronic eyelid edema, the nausea when fasting, and the muscle cramps and the skin hypopigmentation is not something which disappears over time. With nilotinib, it's not very convenient to take a drug twice daily in a fasting state for years and years. We may also have some patients complaining of body hair loss and hitching of the skin due to skin rash. For ponatinib, we know about the erectile dysfunction, and with bosutinib, the gastrointestinal discomfort on a daily basis, and with dasatinib, the fatigue. So I show here the imatinib tolerance profile, a very long term, which was published by our colleagues from the German CML group, because we usually hear that ponatinib is the imatinib, sorry, is really, of course, it's the less potent ATP competitive TKI, but we very often hear that it's really safe as compared with second-gen TKI or third-generation ATP competitive TKI. But this is not really the case, as I said. Look at the edema, the gastrointestinal, the myalgia, arthralgia, skin fatigue, and so on. They are quite frequent, although usually of low grade, and they may really bother the patient on a daily basis. Of course, they are most of the time dose dependent, and we may decrease the dose of imatinib to increase the tolerance profile of the medication. But as it is the weakest TKI with respect to BCR-ABL inhibition, we have a little possibility for dose decrease, because the probability to lose the efficacy of the drug, so to lose an optimal molecular response, is important upon dose decrease of imatinib. So this makes the choice of a TKI in the first-line setting a little bit complex. And in 2013, experts from the European Leukemia Net recognized, and I think it was the case all over the world, that of course efficacy of a treatment is important in CML, but the treatment choice does not only depend on efficacy. And here are the complex way of choosing a TKI when we have access to many different TKIs in the first-line setting. The first step, of course, is to assess the CML risk, because we know that especially in patients with a high risk, second-generation ATP competitive TKI do better than imatinib. So we need to evaluate the prognostic factors, the CML phase, the CML risk scores, whether high-risk additional chromosomal abnormalities are present. I like to add the BCR-ABL transcript type because we learned this year that, as an example, with allosteric TKIs, especially asciminib, the patients who had very rare transcripts with an A3 rearrangement were not sensitive to this drug. And we also know that some patients with a P190 and E19 transcripts have a lower probability to have optimal response than the others when we use ATP competitive TKIs. And currently, we don't use mutations in the other genes than BCR-ABL, but I'm probably sure that it will come in the routine practice to evaluate prognostic factors, as some mutations, such as ASXL1, provides a lower chance to achieve an optimal response. The second step is to look at what are the first-line available options, which may vary from a country to another or from a healthcare system to another. TKI type, TKI strength with respect to BCR-ABL, and of course the off-target effects, and put this data in front of the patient profile, because we know that some side effects are strongly affected by age. This is the case, as an example, for dasatinib and pleural effusion. Comorbidities also play a very important role in the tolerance profile of TKI, and this is true for the cardiovascular risk and for also the metabolic abnormalities. And we also need to figure out what is the lifestyle of the patient, as taking a drug twice daily in a fasting state may not be very convenient for many patients and may lead to decreased adherence to treatment. And also the expectation of the patient to just feel safe on the drug, or also try to be among those who will be treatment-free in a couple of years. And then we choose the TKI treatment with all of this data, and we try to tailor, whenever possible, the first-line medical therapy according to CML prognostic factors, but also to patient profile in order to try to have the highest chance for progression-free survival and TFR whenever possible, but also while ensuring the tolerability and the safety of the treatment. And as an example of what we were doing a couple of years ago in my center. We may change this with expanding first-line option in very soon, but we were in the most very elderly or very frail elderly. We used to prefer imatinib over second-generation tyrosine kinase inhibitors due to what I mentioned before on the comorbidity, the age, and the tolerance profile of the second-generation tyrosine kinase inhibitor. For the lifestyle, it's true that for some patients who are very active or for young adults or teenagers, QD dosing is preferred. So when we used to choose a second generation TKI, it is true that it's easier to use dasatinib or bosutinib than to prescribe nilotinib. And depending on the type of comorbidities, dasatinib or bosutinib if high cardiovascular disease or diabetes, nilotinib or bosutinib if chronic lung disease, and nilotinib or dasatinib in case of hepatic or gastrointestinal disorders. Now the situation may change, and the way we may change the treatment in the first-line setting whenever allosteric tyrosine kinase inhibition may become a new weapon, this may change. The advantages of allosteric inhibition are the following. It's a highly specific inhibition for its target, so a lower probability for inhibition of other kinases, and so less probability of drug-related adverse events. And we know in vitro, but also from clinical trials with asciminib, that these drugs have the capacity to overcome some aspects of orthosteric drug resistance, orthosteric being ATP competitive inhibition of kinases. And with respect to asciminib, that you all know, it's an allosteric inhibitor of BCR-ABL, and it has been approved a couple of years ago already in the third-line setting or beyond, having shown that it was capable to overcome resistance to ATP competitive TKI, and also that it was doing better than bosutinib in the third-line setting, and that the tolerance profile was very favorable. So based on all this data, the development of the drug is going on and moving further, and especially in the first-line setting. There are 4 different ongoing trials. 2 are investigator initiated. This is the case of the ASCEND study, the Australasian Leukemia and Lymphoma Group, and this is published this year in Blood 2024, giving first-line asciminib in chronic phase CML adult patients, possibility to increase the dose based on specific molecular responses at specific time points. And the co-primary endpoints are the early molecular response at 3 months and the MMR at 12 months, and the preliminary, but it's not comparing asciminib to the current strategies that we use. So it's not a comparative trial. It's very interesting, but it doesn't tell us what's the advantage of using asciminib as compared to ATP competitive TKI upfront, but very interesting data anyway. The second trial is a fascination study from the German CML study group. Here again, asciminib is not being compared with ATP competitive TKI. In fact, it's a pilot study in combination with ATP competitive TKI. Some patients treated with asciminib plus imatinib or plus nilotinib or plus dasatinib, with a primary endpoint an MR4 at 1 year. So here again, this trial doesn't answer the question of what's the advantage of using asciminib as compared to what we have. It's a very interesting trial, but unfortunately, it's in this trial the ATP competitive TKIs are given full dose, so the advantage of the better tolerance of asciminib is decreased by the fact that it's combined with a full dose ATP competitive TKI. So we end up having the same problem of the tolerance of the treatment because of this combination strategy. Now we come to the industry-sponsored study, and I'm going to focus mainly this talk on ASC4FIRST because it's a randomized study, international study, many countries. Asciminib is now being compared to investigator-selected TKI, so either asciminib or second-generation TKI upfront, with a primary endpoint MMR by 48 weeks. And We currently have the 1-year data. And the last one is Act for Start. No result yet, but recruitment has ended, comparing asciminib to nilotinib upfront and tolerance as a primary endpoint. So this trial in the years to come will give us specific answers with respect to the advantage of using asciminib versus second-generation tyrosine kinase inhibitor upfront. But let's look at ASC4 first and the results that were presented this year and published in the New England of Medicine. This trial focuses on adult patients with newly diagnosed chronic phase CML, and the stratification is made using 2 factors. The first one, the ELTS risk category, and second, the pre-randomization TKI selection. So in fact, here the doctor had to say what ATP competitive TKI he would have chosen for his patient before the randomization. And that explains that you see 2 different groups in the asciminib and the ATP competitive TKI arms. You see here asciminib. The imatinib stratum is a patient who received asciminib, but for whom imatinib would have been chosen whenever randomized to the other arm, and so on and so on. So let's look at the characteristics of the patients that were included in this study. Nothing very surprising as compared to what we know with CML, at least in Western countries, the median age around 52 years. But we can see that the patients who are in the imatinib, either randomized to imatinib or asciminib, but would have received imatinib, they are a little bit older. And this is explained by the fact that we usually use imatinib, as I said before, in patients who are who are more comorbid than the younger and who are older because of the risk profile of the drug. And we usually use more frequently second-generation ATP competitive TKIs in the younger patients who have a lower risk for drug toxicity. So I separated the results I'm going to show depending on whether asciminib was compared to imatinib or to second-generation TKI, because this is really the way we want to look at the data. So here, if we look at the patients who are treated with asciminib as compared to imatinib, we see that this is the efficacy, so this is the molecular response, and we clearly see that asciminib is more efficient than imatinib. And this is not a surprise, of course. Asciminib is a very strong inhibitor of BCR-ABL. Look at the EMR rate at 3 months, 88% versus only 59%. The MMR at 48 weeks, 69 versus 40%. And of course, 1 year of treatment is pretty short in order to assess the deep molecular response rate. But we already see that at 48 weeks, so about 1 year, patients in MR4, 40% for those treated with asciminib and only 14% for those treated with imatinib. So almost twice more efficacy in the asciminib arm versus in the imatinib arm. And this is illustrated by the fact that the patient who discontinued treatment due to unsatisfactory therapeutic effect was 3 to 4 times lower in the asciminib arm than the imatinib arm. You see 20% of patients quit imatinib during the first year, and only 6% quit asciminib due to unsatisfactory therapeutic effect. This is also the case we see for adverse event. 11% almost of patients left imatinib due to intolerance, and only 6% quit asciminib due to intolerance. And I will focus now on the patients who were assigned to asciminib and those who were treated with second-generation tyrosine kinase inhibitors. Unfortunately, we cannot separate in the second-gen arm the patients treated with imatinib, dasatinib, and bosutinib. What I can tell you is that there were very few patients for whom bosutinib was chosen. So this arm contains mainly patients treated with nilotinib and dasatinib. So here we see that asciminib is doing a little bit better. with an EMR rate 91% with asciminib, 80% with second-gen TKI. Of course, here the challenge for asciminib is higher than when it's compared to imatinib, because we know that second-gen TKI are much more potent than imatinib. But still, you see that asciminib is doing a little bit better, although here the difference is not statistically significant. But you see MMR at 48 weeks, 66% versus 58% with second-generation TKI, and already probably more higher rate of deep molecular responses at 1 year, 35% for MR4 and 10% less for second-generation tyrosine kinase inhibitors. So, and this is reflected also by the fact that a lower proportion of patients left the study due to unsatisfactory therapeutic effect. You see 6% here for asciminib, who would have been assigned to second-gen whenever randomized to the other arm, and 10% for those who receive second-generation ATP competitive TKI. We also see that the patients who left the study due to intolerance are twice less when they receive asciminib, only 5%, and about 10% for patients who receive second-generation ATP competitive tyrosine kinase inhibitors. What about the tolerance profile of asciminib versus the other medication? Here you see all patients treated with asciminib and all patients treated with second-generation tyrosine kinase inhibitor. We clearly see that with respect to GI symptoms, there were much less with asciminib. Diarrhea, 25% with second-generation tyrosine kinase inhibitor, 10% less for asciminib, much less nausea, only 9%, twice more with second-generation tyrosine kinase inhibitor. When we look at general symptoms, it's also some are decreased, especially the skin toxicity is much lower, 13% for rash, 21% for second-generation tyrosine kinase inhibitor, much less headache, 13%, 21% with second-gen tyrosine kinase inhibitor. Fatigue seems to be more or less the same, 14% versus 17%. So let's hope that in the future, this kind of symptoms will decrease, but we have to wait for a longer follow-up. When we look at laboratory values, especially the increased lipase is quite frequent, 10%, same with ATP competitive TKIs, but usually not associated with clinical pancreatitis. So this may question the usefulness of dosing lipase systematically in our patients. And there is very little liver toxicity, which is not the case with ATP competitive TKI. Especially we know that with bosutinib and with nilotinib, the liver enzymes may be elevated, and this really requires attention. There are some open questions. Of course, these are preliminary results from ASK4FIRST, and these are very interesting. Tell us that asciminib is doing much better than imatinib and may also do better than second-gen TKI because of the very high BCR-ABL inhibition potency and the better tolerance profile. But we need to dig a little bit more into depth because we would like to have the real tolerability profile of asciminib compared with the three different ATP competitive TKIs. Here you have seen that they are all mixed together in the same arm, and we would like to know specifically whether it's better than dasatinib, nilotinib. For bosutinib, we already have some data because in the ASSEMBLE study, which led to the registration of the drug third line, we directly had the comparison of the tolerability profile of asciminib with that of bosutinib, and we knew that the patient felt much better on asciminib than on bosutinib. Now, we also would like to have the tolerability according to age or to comorbidities, because we know that for ATP competitive TKIs, age and comorbidities play a very important role. Age is a risk factor for pro-refusion on dasatinib. It's also a risk factor for anemia and for edema on imatinib, and comorbidities also increase the toxicity of nilotinib and ponatinib as an example, although it's not first line, with respect to the risk of arterial stenosis. Now, with respect to efficacy, I'm sure that very soon we will have some more data into asciminib efficacy according to CML risk scores. You remember that with a second-gen ATP competitive TKI, we used to say for patients with intermediate or high risk, it's very important to give, if possible, a second-gen TKI because we decrease the probability for accelerated phase or blast crisis. Whereas for patients with a low SOCOL score, this was not the case. The risk for progression was already very low, although we know that for patients with a low risk score, the probability to have a deep molecular response was much higher with a more potent tyrosine kinase inhibitor. So here, we would like to know what's the advantage of asciminib first line in patients with a low CML risk score and intermediate or high as compared to what provided with the ATP competitive TKIs. I personally also would like to know what is the exact proportion of patients who fall into the optimal, the warning, or the resistant category during the first year of therapy with asciminib. We know that the patient who failed treatment are not, the proportion is not high, but it's very important to know step by step who is falling in these three categories, because this is the way we measure the response and we measure the efficacy of the treatment in our patients on a daily basis. The trial will not answer whether it is worth to increase asciminib dose at specific milestones in order to maximize the probability to achieve treatment goals. Let's say, should we use higher doses in patients with a high risk? Unfortunately, the trial was not designed for that, and I guess we may have investigator-initiated study to study this possibility. We know already that asciminib dose is very important in patients who have resistance, especially those with specific mutation. We don't know what's the role of AGA, so AGA, additional genomic abnormalities in resistance and warning to first-line asciminib, but this data will come in the few years, especially SXL1 mutations, who are supposed to provide a lower probability for optimal response with ATP competitive TKI. Is it the same with asciminib or is it different? And we also need to know a little bit more about the frequency of asciminib-resistant mutation and how to overcome this. And we already have some preliminary data from ASK4 first. We are the patient who left the study for unsatisfactory therapeutic responses. And here are the post-baseline emergent mutation, both in asciminib arm and the ATP competitive arm. And you can see that there were 8 patients in the asciminib arm, so 4% who left the trial with a BCR-ABL KD mutation, and half less with ATP competitive TKI. So this is a little bit of a surprise because we knew that when we used to use a second generation ATP competitive TKI as compared to imatinib, at least in the study that led to the registration of this drug, we used to decrease the proportion of patients with mutation, and this is clearly here not the case. You see 2% of patients with imatinib had mutation and only 2% with second generation ATP competitive TKI. So overall, 4%. The second information, which is also very important, is that the mutations are not of the same type. And with asciminib, the patient who developed mutation, you see here that they are mainly located around or in or around the myristoyl binding site, the site where the drug binds. Whereas for ATP competitive TKI, it's mainly mutations that we already know in the KD domain or in the P loop, like here, the Y253. So these are mutations we are not used to deal with, and we need to know how to fight these. Here's, and I thank Thomas Lyon in Austria who gave me this slide. You see asciminib here on the left-hand side binding to a myristoyl binding site. In blue, the ATP competitive tyrosine kinase inhibitor binding to the ATP binding pocket. We know that when there is a T2-alpha-Y mutation, you need to use high doses of asciminib in order to be efficient. But clearly, here are the resistance-associated single mutations for asciminib. and many of them are located in the myristoyl or around, but there are some who are mutations that we also see with ATP competitive inhibitor, like the M244V of the F359V. There are also some resistance associated with compound mutants, but fortunately, these mutations are very rare in the clinical setting. So for patients who may develop resistance to asciminib, especially associated with KD or myristoyl binding site mutation, do we have the possibility to rescue them? We need to accumulate some data, but the answer is yes. In clinical practice, we can rescue the patients either by using ATP competitive TKI salvage drug, the one what they already have, but there are also other in development, like the N11, which is also very interesting because it inhibits T315I and is also supposed to be very selective. We have other allosteric TKIs under development, and what they will bring as compared to asciminib is something we will ask in a few years. And maybe one day we will have also these PROTAC approaches to bring BCR-ABL to the ubiquitin degradation pathway, and combination therapies, of course. So to conclude, why survival rose incredibly with ATP competitive TKIs, there are other factors that come to the forefront for our patients, and these factors require increasing attention to continued health problems and needs of our patients. The drug-related toxicity tolerability, the impact of treatment on the daily life, work, family, leisure, or socialization, the convenience and the flexibility in treatment administration, and of course, the treatment-free remission. And among the new treatment goals, when patients already have great treatment choices and feel protected from the treatment, then relapse threat-free life and a normal functioning becomes very, very important. And I guess that based on the preliminary results that we have, asciminib first line may help reaching some of these ambitious new goals based on these preliminary results I showed you. But of course, we need to recognize that a longer follow-up of patients enrolled in the first-line study is needed. And I would like to thank you very warmly for your kind attention.
Thank you, Dr. Delphine. That was fantastic. You really updated us with the asciminib data, especially in the first line, which is so new. Our colleagues are here, and I'm sure they would like to discuss things with you. Meanwhile, can I ask you one question? There are two doses scheduled, 40 mg twice a day and 80 mg once a day. Is there a difference in the pharmacokinetics with these two schedules, or both are equivalent?
The half-life of asciminib is sufficient to give the drug once daily. And I personally never give the drug twice daily, although this is the current label in the beyond the first-line setting. I guess this label will change anyway because Novartis has launched a study called As4Opt, in which asciminib for 40 BID is being compared to 80 milligram QD. Of course, the results have not been presented yet. The reason why I'm using it QD is also because I was one of the persons who contributed with my patients to the first-line trial with many patients being given the dose, the asciminib QD, and currently there is no good reason to give it BID. The only reason was probably to develop it this way, but I mean the pharma would talk about this better than I do because this is really not my field. The idea was maybe a dual inhibition at the beginning, and this is really mentioned in the Nature paper from Willie et al. And the hope was to do a dual inhibition, so maybe to use it BID. But currently, as a single drug, it's very important, as I said, for adherence to treatment and to incorporate the treatment in the daily life of the patient to give it QD. And there is no loss of chance and a much higher tolerance to lifelong treatment or many years duration of treatment.
Thank you. So we have...
So can I ask a question?
Yes, please go
ahead. Ma'am, a very elaborative talk regarding CML. And patients who are upfront having ASXL1 mutation, do we have any preference of additional therapy for them? Like, would we take them for transplant upfront? Is there a provision like this?
So what we know, there are very few prospective data on the impact of these mutations on the outcome. Most of the studies have taken patients with resistance and went back to the original diagnosis sample. So we know that ASXL1, there's only one prospective study, and this is from the German CML study group. So we know that it's the probability to have an optimal response is decreased, but it's still very high. So the sole presence of ASXL1 is not at all, in my opinion, a reason for transplanting the patient, because most of them will respond very well and you will manage to kick out the clone. But for some, it's not the case indeed, and we see that the presence of ASXL1 is also associated when there is a resistance to a higher probability to have an ABL-KD mutation. We don't really know what's the mechanism of that. With respect to combination treatment, I mean, should we, for those patients with an SXL1 mutation who don't respond very well to monotherapy, should we combine a treatment? Maybe, but what combination? At least as far as we know right now, ASXL1 is not a very easy druggable target. So we need to have more insights into how ASXL1 abnormality, what are the modifications within the CML cells that leads to resistance and that leads to the higher probability of to have a BCR-ABL-KD mutation. And probably how to block ASXL1 modification in the CML cell is something that we don't know right now to do. So currently, I think it's a warning sign. But I would not transplant right away these patients, as many of them will respond them, and some of them who develop KD mutation may be rescued by changing the TKI.
Thank you, ma'am. Thank you so much.
Thank you. Dr. Hita has a question for Dr. Sanjeev. What percentage of Indian patients are T315I mutated? Do we have any data and any data on the survival of such patients?
T315I mutation is the most common mutation in all international as well as Indian studies as well. And out of the mutations, almost 17 to 25% of mutations are T315I mutation. In our unpublished data of 545 patients who have been evaluated for mutations, 117 has mutation, and T351 mutation is the most common mutation, with 37 patients having T315I mutation.
Second part she wants to know is the survival of such patients in India.
There is a very poor outcome data. In fact, there are only case reports. Nobody has published the case series for T351I mutation survivals. Transplant and newer drugs like ponatinib and asciminib are the treatment option for this patient. But considering the very high treatment cost with continuing TKI with asciminib or ponatinib, bringing them into remission, deep molecular remission, and then doing transplant is the good treatment strategy for this patient.
Thank you. Dr. Ria, there are some questions for you. One question is regarding ultimate choice of first-line therapy, ATP competitive versus now these new molecules. So what is the pattern in the Western world now? Are you changing from the ATP competitive to asciminib?
So currently, asciminib is not labeled first line. As far as I know, probably US will be the first part of the world who will have access to asciminib first line. I'm not sure FDA has approved it yet. And the other part of the world will come later. At least I know in Europe it will take more time. The process for registration is very different in Europe. And once a drug is approved in Europe, it's not enough to have access to the drug. Each country has to decide whether the treatment is worthwhile to reimburse or not. You know that treatment costs will be very high as for all innovative drugs, while for ATP competitive TKI, we have generics. At least for imatinib, we have generics for dasatinib. For bosutinib, it will come at the end of the year. And for nilotinib, it's also something which should come very soon. So, of course, there are some cost issues. So right now we are still using ATP competitive TKI first line, but I'm sure that once asciminib comes, it will be something that will need to be considered. Clearly, I think for elderly patients, or those who have high comorbidity burden, it's very interesting because the tolerance is very good, and this will bring more patients to TFR than with imatinib. And I think here the picture is really clear. Of course, we need long-term data in order to make sure that comorbidities will not impact the long-term tolerance profile of the drug. But hoping that more patients for which we would have used imatinib will bring to TFR, maybe the cost of treatment overall will decrease in some way, at least in the long term. Now for second-gen TKI, of course, we know that the tolerance profile of asciminib is very good, but we need to know a little bit more. And this will be an issue, I think, for health authorities, especially in Europe. And we have this very large trial from the pharma, from Novartis, comparing head-to-head asciminib with nilotinib. There was no patient with dasatinib in this study. It's really with nilotinib. But this will allow us to have more data of what are the advantages of using asciminib as compared to nilotinib first line, both in terms of tolerance and in response. So, and I guess this will be an issue, maybe not in US or in other parts of the world, but for Europe, this is going to be really an issue of whether the drug should be reimbursed for everyone first line or only for a subset of patients.
Thank you. The other question is whether asciminib will be the preferred third-line TKI for all the patients.
It depends on why you need a third-line drug. I mean, there are some patients who need a third-line drug because they are intolerant to ATP competitive TKIs, but they respond well. So, and there are some patients who need the third-line drug because of resistance. And we know that asciminib has some weaknesses with respect to resistance. Still, one of the strongest TKI to fight resistance is, in my opinion, and based on the available data, is ponatinib. Ponatinib has really, maybe over imatinib, but I don't know very well these drugs as it's only used in China right now. And we start to have a little bit of data from an international study, but the development is still ongoing. But we know that asciminib doesn't fight all resistance associated with BCR-ABL mutations. So the spectrum of activity of asciminib is lower than that of ponatinib with respect of mutations. So asciminib cannot fit to all patients in the third-line setting. It really depends on the background of the patients and the background of CML response history to prior treatment. It's a very good option, but not for 100% of the patients.
Another question is, where does the transplant fit in patients who have reached the third line of treatment?
So as I can hear from your experience and from what our colleagues said before, I think you mentioned that for cost issues, at least with some salvage drug, some patients who are brought into remission, as an example, with ponatinib or with high-dose asciminib, are brought to transplantation, not for efficacy issue, but because long-term treatment is too expensive. And of course, this is we have a different situation in other countries. So in our country and in Europe in general, the patients who tolerate well a salvage treatment third line and who has a good response is not going to be transplanted. So the transplant attitude is a little bit different around the world. And in our practice, we bring patients to transplant, of course, those who had progressed to blast crisis. And in the third line, not progressing to blast crisis, those who are resistant, who cannot be salvaged by any of the drug currently available.
Thank you. Yes, Dr. Narendra Chaudhary, your question.
Thank you, sir. My one question to Dr. Ria is asciminib study available for children also? Is there any study results out? Because I was aware that ACE for kids one study was started, but any interim results or any idea about the experience in pediatric age group? And second question I will ask later.
Thank you very much for this question. So indeed, there is a study ongoing in children, so we will have answers soon, and this is very important. And one of the very important points for the children are the growth issues, because we know that they lose between 1 and 1.5 standard deviation in growth when we use ATP competitive TKI. We don't have the data available yet for asciminib. There was one presentation 2 weeks ago in Prague during the ASH ICMLF Congress, where apparently in vitro asciminib would not disturb so much the bone metabolism as compared to ATP competitive TKIs, but whether this translates into a better growth is not known yet. So we need to wait a little bit to have some results.
Yeah, thank you. And another question is, any of you can answer, or both of you, that we usually monitor the BCR-ABL status in peripheral blood. But in one patient with ALL, which was Ph positive ALL, in that we have seen that in peripheral blood it was negative, but when we did bone marrow, because of some cytopenia which was going on, for that we did bone marrow to monitor BCR-ABL, that was found to be positive. Though cytopenia improved automatically and it was not any like disease process causing cytopenia, but incidentally we did bone marrow, routinely we don't do, and found it positive. So what is the best sample to monitor, whether it is peripheral blood or bone marrow? If we leave the because it is more convenient, so we use peripheral blood, but for to pick up more cases, whether bone marrow is better. And I was going through one study, actually that study suggested that peripheral blood is having more stringent BCR-ABL levels than bone marrow. So what is your take on this subject?
So thank you. So for chronic phase patients, it has been shown that there was a very good relationship between the blood and the peripheral blood and the bone marrow. But for patients who have progressed, indeed, it's very important to have a bone marrow analysis in parallel to blood, as there can be some discrepancies between the two. So my answer would be depends on the phase of the disease. For chronic phase, it's fine. But for blast crisis, the bone marrow sample is very important.
Dr. Sanjeev, any your
For
experience?
for
Because in
pH
India, we
positive,
face this situation very frequently.
I have encountered this situation. For pH positive ALL transplant follow up, we do the MRD and we take sample for BCR-ABL as well from bone marrow aspirate sample only. Not for CML. CML we do by peripheral blood only. But pH positive transplant follow up, definitely with bone marrow, we do the MRD as well as BCR-ABL monitoring.
Okay, thank you.
Dr. Narendra. Dr. Avriti?
Thank you, sir. Thank you, ma'am, for this wonderful session. Ma'am, first of all, for TPO receptor agonist, ma'am, what has been your experience like giving it in cases who have developed hypoplasias, whether there are chances of any progression of the disease in CML?
In my personal practice, I use TPO agonist during the first 3 or 6 months in patients who developed deep thrombocytopenia in order to avoid interruption of dose decrease of TKI treatment, and also in order to avoid complications from bleeding complications, and I have not seen any problem with that. There is a small case, of course, it's not labeled for this indication. There was a small case series from Jorge Cortes and colleagues. At the time, he was at the MD Anderson. They had an experience of L-thrombopag in patients with cytopenia, both with CML and with myelofibrosis, and from their study, there was some interest in using this medication to avoid, as I said, treatment interruption of bleeding complication. And as far as I know, there is no warning sign about potential blast crisis for these patients.
Thank you, ma'am. And ma'am, my second question is that, ma'am, effect of the drugs on, like, if the patient is having certain rheumatological disorders, is there any effect on the extra-articular manifestations of rheumatological disorders? Because I have few cases of CML with rheumatological issues, and most of them, they have increased in extra-articular manifestations. So, ma'am, is there any experience like this, and how to go about all these cases? And the patients are not able to achieve the molecular targets as well.
There's no large case series about this. What we can see is that you're talking about psoriasis or this kind of skin disorders, or
Ma'am, some of them have eye issues, ma'am, like they have some blepharitis or some eye issues like that, or maybe redness of eyes, or at times skin issues. And ma'am, they are not able to achieve the molecular targets even after switching of therapies, and despite of absence of any mutations.
okay. So we are not aware of the fact that there may be non-hematological manifestations associated with a lower chance to achieve optimal responses. So this is interesting what you are talking about. I know that when I use nilotinib in patients who have a history of psoriasis or eczema, the skin problems with the TKI increase, but I could rescue these patients with other ATP competitive TKI. So there may be other factors associated which may explain a lower rate of response. Do these patients have an inflammatory background? Do they have mutations outside BCR-ABL? This would be interesting to study these specific cases, but I'm not aware of publication mentioning that the rate of response may be lower. So I guess it may be an indirect effect, as I said, maybe a general inflammatory background or chips. And we will need to, I cannot answer your question with a more precise way, but I think there's work to be done here if you observe this very frequently.
Thank you very much, ma'am.
Thank you, Dr. Avriti. Dr. Salesh wants to know, is there any data on asciminib as the post-transplant maintenance?
There are some patients, some groups who use asciminib indeed as a post-transplant maintenance, but I cannot tell you. These cases are not a large series, I think the efficacy will depend on whether asciminib was given after resistance to other TKIs or not. Some patients are quite fragile, and now they receive asciminib in combination with chemotherapy as an induction of complete remission and then being transplanted. So in that case, it's understandable that they receive the same TKI as before. But for patients who had been resistant to other drugs, and we need to make sure that asciminib post-transplant will be able to target all kind of ATP KD mutation that the patient might have before. So this is being currently done. There are no large series telling us under what circumstances this is an interesting strategy or not. I guess these patients are quite rare and quite heterogeneous in terms of disease history prior to transplant. So it's not something that should be generalized, but study on a case-to-case basis to see whether this strategy may indeed be successful.
We have one patient who has all 3 lines failure. He is non-T315I mutation, but he was treated with asciminib and bring into molecular remission. Then the patient was transplanted. He is on asciminib maintenance post-transplant. Day 100 it was started. We have planned for give at least for 1 year post-transplant asciminib.
Here you are giving 80 per day?
40 milligram BD.
40 BD, yeah. Sure.
Yes.
Okay. Dr. Deep Gala has a question. He has a patient where imatinib failed, and on second generation TKI, there is severe pancytopenia. How do you approach this scenario?
These patients are really very difficult patients to salvage. I guess a try for a less hematotoxic drug is worse, like asciminib third line. But very often, but the success will depend on whether there is still some normal hematopoietic reservoir or not, and whether because some of these patients might have an indication for transplantation. Some of these will never recover, regardless of what TKI you choose later on. And it's probably because of either they don't have normal hematopoietic stem cells anymore, or so low that the normal reservoir cannot grow, or because the hematopoietic stem cells non-PH1 that they have is also not normal anymore and maybe has some mutations. So these patients will never be rescued by any ATP competitive or allosteric TKI. So I think in these patients, it's very important to perform HLA typing, try to figure out whether there is a donor. Of course, you may try asciminib as an example, because some of them may be rescued, but not all, and be ready for transplant whenever rescue is not successful. So you may have the answer within 3 or 6 months to salvage treatment with asciminib. So either there's a success and you can and the normal hematopoiesis will recover, or the cytopenia will recur, and then you need to bring this patient to transplant.
Thank you. Dr. Priyanka has a question. That ASH recommends that if there are more than 5% lymphoblast, one should do upfront transplant in patients. So do you look for the blasts upfront?
So this is very important in CML to have the bone marrow analysis at diagnosis, although we know that most of the time the bone marrow reflects the blood, and if you have a chronic phase in the blood, usually you have a chronic phase in the bone marrow. But you are absolutely right, dear colleague. In some patients, very few, but bone marrow is important, otherwise we misdiagnose. There will be a lymphoblast below the 20 or 30% threshold, and this is a blast crisis indeed. The proportion of lymphoblast, there should not be any lymphoblast, even if it's a low percentage. So this patient should be treated as lymphoid blast crisis upfront. Whether they should be systematically transplanted after induction of remission, probably not all. When we are able to discriminate between BCR-ABL residual disease and IGH-TCR rearrangement, there are two kinds of patients: those who will have a disappearance in the lymphoid blast clone, so disappearance of the IGH-TCR residual disease, but CML still present. So BCR-ABL eventually detectable, but not the IGH-TCR positive cells. And there are some patients where if the IGH-TCR rearranged cells are still there, then indeed it's an indication for transplantation, as this patient is not cured from blast crisis.
Thank you. Another question: in a young woman desiring pregnancy, would you prefer asciminib as the first line of therapy for a quick TFR?
So in a young woman without comorbidities, currently we use the strongest TKI that we have, so second generation TKI upfront. What's the advantage of using asciminib over second gen TKI with respect to TFR? I don't have the answer yet. You have seen that there's a little bit more of deep molecular response during the first year of treatment with asciminib as compared with second gen TKI, but the difference is not very high. So right now, the answer is there is no argument to think that it will do better. We need long-term data for that.
Thank you. Dr. Kanan has a question whether there is any data of asciminib as the second line.
So you have seen that asciminib has a label third line or beyond, and it's going to apply for a registration first line. So what about second line? Of course, there's a gap here. There is a study in US, but as far as I heard, the recruitment is not going very well. But there was a huge study, it's a paradox, but from our American colleagues presented in Soho, Houston, and also in different congress, that they have a lot of patients off-label. So they have a series of 90 patients treated with asciminib second line off-label, whereas the trial doesn't recruit very well. And indeed, we start to have some real-life data with asciminib second line. We are clearly waiting for a clinical trial because it's very important to figure out what's the role of asciminib in a second-line setting. Of course, it may have the label first line, but it's not going to be used everywhere around the world for availability issue, price issue, and so on. But it may be a very good second-line option, especially in patients with a high comorbidity burden, for which you use imatinib first line as an example, or who had second-gen TKI with comorbidities, and then you want to switch to a better, with a drug with a better tolerance profile. So we're still waiting for this kind of data. There is some real-life data, but no data coming for clinical trial.
Thank you. The question whether you will do mutation studies upfront to pick up 315 mutation so that you can give appropriate therapy upfront.
Do you mean at diagnosis?
At diagnosis.
At diagnosis. In fact, it's very rare to find a BCR-ABL mutation at diagnosis. It has been published a long time ago. Very few patients have mutation, and we still wonder whether these patients were truly in chronic phase or whether it was unrecognized blast crisis or contamination of PCR in the lab. So it's not very useful to do a mutation profile at diagnosis. I mean, BCR-ABL mutation, of course. There's no reason to choose the treatment according to this. It's a waste of money. Most of the time you will find nothing. So it's not a guide to choose the treatment. It's a guide to choose a second or a third line treatment, but not a first line treatment in chronic phase.
Dr. Sanjeev, question for you from Dr. Shyam. Indian data about allotransplant in CML who have developed 315 mutation.
There are case series published, but we can have data from ISBMT. The CML group is working on that for collecting data. ISBMT has made some groups for data collection in separate groups. In that they are doing. So very soon there will be paper on 315 mutation transplants in Indian setting.
Thank you. Dr. Hita has a question about 315 mutation. So vis-a-vis, how do you choose between ponatinib and asciminib? Dr. Delphine.
So currently, it's difficult to use asciminib because of the high dose requested for T315I, and for cost issues and for label issues. But clearly, right now, if I would have access to both options, I would prefer allosteric TKI first, because of the cardiovascular and tolerance profile is better than that of ponatinib. So for tolerance issue, I would use an allosteric TKI and keep ponatinib afterwards whenever needed.
There are many T315 plus non-T315 associated mutation in which asciminib is not working. In that situation, ponatinib is the only option remaining with us, and ponatinib is only not working in a particular mutation, that is T315M mutation. That is the only main known mutation where ponatinib is not effective. So in that sense, I think ponatinib is more important in situation, especially with double mutations.
Thank you. Another question is from Dr. Salesh. What is the response to asciminib in patients after TKI failure if there is no BCR-able mutation at all? Do they do better? No mutation.
Indeed, I think we missed this kind of data. When you look at the data from a sample, there were a few patients who were enrolled with a BCR-able mutation at baseline. And it's true that we would like to have this kind of data. We have this kind of data for ponatinib. And clearly we know that ponatinib works better if there is a T315I mutation than where there is another type of mutation or where there is no mutation. But to be honest, we miss this kind of data for asciminib.
Dr. Thank, your question.
Yes, Madam, thank you for the comprehensive talk. We have a case of CML, chronic phase, consistent with peripheral and bone marrow features are consistent with CML, but BCR-ABL became negative. So may I know your approach? His CBC initial white cell count is more than 300 and began reduced with TKI hydroxyurea. And spleen is 10 centimeter initially and began to 2 centimeter with treatment. But BCR-ABL result began negative. Yes, may I know your approach?
So if you are sure that there are no BCR-able transcripts, both major type and minor or micro, then it's not CML.
P210 and P190.
Sorry?
P210 and P190 are negative.
Negative, but there are other types of minor transcripts. There are other type of rare transcripts. So you really need to be sure that all of the variant transcripts that have been described are not here. So as an example, either FISH positive or negative, FISH analysis.
Or he cannot afford for fish.
Not done.
Okay.
So should I proceed TKI or not? Yes, continue.
Okay, so you cannot afford. So you can try TKI. Let's say it's probably not CML, but you're not 100% sure because you cannot figure out whether the patient has a very rare transcript or not. If he has a very rare transcript, then it's CML, then he will respond to TKI. So you can give a try for 3 months and see, even in 1 month, if you have CHR, you're sure that there is BCR-able somewhere. It may be a variant transcript that you're not able to characterize. But if there is absolutely no response, it means that it's another disease, and there are other diseases that look like CML, like the atypical CML. The name is not very nice because it's not CML at all. It's associated with mutations in non-able, like ZBP1 and so on. And in that case, you will not have a CHR with TKIs, and then it's an indirect way of knowing whether it's true CML or not. And if it's not CML, then it's probably atypical CML, and these patients never do well. They all transform, and they really need to go to transplant.
Yes. Second question is, may I know your adjustment for prolonged cytopenia for 2 to 3 months with TKI? Yes, and there is no evidence of disease progression.
Yeah, some patients will respond. I mean, for some patients, it's a transient phase. For some patients, there is a delay between killing of BCR-able positive cells and recovery of normal cells. And in that case, the cytopenia will be transient, and that's fine. But for other patients, the cytopenia will remain because the normal bone marrow cannot recover. And in that case, you will need to transplant if possible.
Yes, thank you so much.
Thank you, Dr. Thand. Another question is, there is some early data about combining asciminib with other TKIs. So your comments on this?
Yeah, there are some data. There are some data in the phase 1 study and also in the fascination study from the German group in the first-line setting. The problem here is that we use full dose of ATP competitive TKI, and the tolerance of asciminib in combination with full dose imatinib or full dose nilotinib is not good. You increase the adverse event related to nilotinib or asciminib, and the patients don't feel well. With asciminib and dasatinib, there is no such issue. So clearly, if we want to go on with combination treatment, we need to change completely the way the doses are decided. And we need probably to decrease the dose of ATP competitive TKI and to increase the dose of asciminib.
Thank you. Dr. Arun has put a question. Do you think a double-blind randomized trial would have been better to avoid the bias with respect to adverse events in an open-label design of S4 first trial?
I like your question because last week we had the young residents for article analysis, and one of the young residents had to criticize and to read Ask for First, and she raised the same point. So my answer is double blind is really the theoretical perfect way. But in the real life, I can guess who has imatinib, who has nilotinib, who has dasatinib, and who has bosutinib, because the side effect profile is very different. So in fact, it cannot be blinded. I mean, you can blind it, but you can guess very, very rapidly which drug the patient has, because the tolerance profile of these drugs are very different. So theoretically on the paper, it's a good idea, but in the real life, you already guess what treatment the patient has. So I think it's not the way to go because of this.
Okay, thank you. That was a very nice answer. He has another question. In a patient started on asciminib for CML chronic phase, first line, is same ELN and NCCN endpoints used to define the treatment resistance or failure? How do we sequence then TKI subsequently in such patients? So whether the ELN and the NCCN endpoints for resistance and the failure definition are same for asciminib as for others?
So yeah, NCCN has already published the new recommendations, including asciminib, which is not the case for ELN, but the definition of resistance will be the same anyway. And you perfectly know that for patients to be protected against blast crisis, an MR2 is largely enough. I mean, MR2 is fine for PFS. MR3 is a little bit better, but MR2 is providing a very high degree of protection. Now for TFR, of course, just an MR2 is not enough. So I guess the definition of resistance, I mean, with respect to the residual disease level will not change, but the mechanisms of resistance may be different, because for asciminib first line, if you have resistance or if you have more than 1% BCR-ABL after 1 or 2 years of treatment, you will need to sequence to know whether there is myristoyl binding site mutation. And these mutations do not occur with ATP competitive TKIs.
Thank you. Another question is from Dr. Sham. If you remove the cost from the discussion, is asciminib the most effective and the least toxic TKI to be used for all the patients of CML-CP upfront?
So you asked me for my personal opinion. Of course, there are some data, but I believe, of course, if we remove cost from the discussion, that yes, in our clinical practice, asciminib is the TKI with which the patient hardly complain about anything. It's very rare. Now it's much more efficient than as compared to imatinib. With second gen, I don't know whether it's the same, whether it's going to be more efficient because the patient tolerated better, which is a different story from being purely more efficient. You know, if you have to dose decrease with second gen because of tolerance, you may lose some efficacy. Whereas with asciminib, if the tolerance profile is perfect, you may maintain full dose during the first or second year of treatment, during which you need to induce a good response. So is it going to be the reason why the rate of response is a little bit higher than with second gen TKI? I really don't know. So let's say for the tolerance, yes, I think it is a winner. For efficacy, it's the winner in front of imatinib, but in front of second gen, let's wait for results for ask for, you mean the second trial that we have in Europe, at least the asciminib versus nilotinib trial, which will be very interesting to look at.
But in the S4 also, you had all the three drugs in the comparative arm, right?
Yeah.
And dasatinib, nilotinib as well.
Yes. Yes.
And asciminib was superior in efficacy.
In terms of tolerance, yes. Less patients leaving the trial for tolerance issues. A little bit less patients leaving the trial for resistance issues. But all the three drugs were mixed together, and in clinical practice, this is not the question that we have. We need to know how does it compare with dasatinib, how does it compare with nilotinib, of course.
Thank you. That finishes all the questions from the chat box. Any question from here? By either Dr. Sanjeev or Dr. Delphine? None. In that case, well, thank you so much, Dr. Delphine and Dr. Sanjeev, for sparing your Sunday morning and being with us and educating one and all. It's extremely grateful to you for doing this. Also, thank Novartis and other companies for supporting this and all our discussants for being with us. Thank you. Bye-bye.
Thank you very much. Thank you very much.
See you in Mumbai in a few months.
See you in Mumbai. Thank you very much for a kind invitation. Bye-bye.